In this episode in our video series on knee pain while running, we're going over medial meniscus tears, or frays, so it can be different grades of it. Now, I'm actually going to go over 7 different methods that we use here at Performance Place for medial meniscus treatment. Now, I want you to understand that in this video, we're going over mainly assessment, treatment, taping, and only one of stabilization or rehab. But you have to understand that the knee needs to have rehab. Okay, I've gone over rehab in other videos on knee pain with runners, so I'm not going to include it on this one, but it doesn't mean that it's important. It is extremely, extremely important. Now the methods I'll show you today is, number one, we're going to confirm the meniscal tear, or at least show you some tests that are commonly used to confirm it. One is THESSALY's test, and the other one is medial joint line tenderness. Next, we'll have to confirm that it is not runner's knee, and we're going to confirm that it is a meniscal injury. And to do this, we're going to use a squat test. After we've confirmed it's a meniscal injury, we're going to do some friction massage on the open joint line. After that, I'm going to show you how to stretch tape, quote unquote stretchy tape, which you've probably seen all over the media, all over pictures. It's that colorful tape. I'm going to show you how to use that on the medial joint line right over the area of pain. The next type of taping I'll show you is the white standard athletic tape. How can we use this to stabilize the medial joint line? Next, we use a different type of taping called LEUKOTAPing, which also can be called tab taping. I'll put this over the medial joint line as well, and this will help decrease pain with motion. Lastly, we're going to go over that one stabilization exercise for lateral stabilization, but again, remember, it is way, way, way more complex than this one exercise.
This is called THESSALY's test, or THESSALY's test, and we usually do it with a bend of the knee around 5 and 20 degrees and retest. Do 3 times per side, and notice she's holding her hands upon the tabletop right there, mainly so we can get rotation about that shin bone or the tibia. Now, we usually do on both sides to make sure that it's pathological or symptomatic on one side, and a lot of times they'll have the experience of it just feels uneasy or unstable. And it won't always really hurt, but it usually always feels at least unstable. And in 2015, we found the sensitivity was around 64%, the specificity was around 53%. It used to be more specific and better in the past, but when you combine it with this next test I'm going to show you, combined they're pretty good.
Now, one test that I really like to combine with THESSALY's test is medial joint line tenderness. It's pretty simple. Slide your finger down, get into that gully right there, and just kind of rub back and forth and just look for areas of tenderness. Combining this test with THESSALY's test is really, really accurate for finding medial meniscus injuries, especially if they have all of the correlated clicking, popping, catching. One way to assess is the squats test. And the squats test is a really simple way. Go ahead, you can start squatting if you like. It's a real simple way of confirming that we're working with a meniscal injury and not a symptom that is coming from the kneecap, such as runner's knee and so on, which is also called patellofemoral pain syndrome. We have a whole other video on that. And notice it right now, so she's squatting in and around 60 degrees. So she's not breaking parallel with her thighs. So go ahead and break parallel for me. Okay? So the difference of these two squats is mainly the depth and the degree. The path is still the same. So in and around 60 degrees, right before that, we're looking at more of a runner's knee patellofemoral pain syndrome if she has pain there. And if she breaks 90, the estimation is around 85% of the meniscus carries the load of the body just below 90 degrees. I'll put a reference on that in the article attached. That was from Warren Hammer. Go ahead and turn the other way for me just so we can see. Hey, Laura. Sorry, I don't have a joke right now. Do you want to hear a short joke?
No.
Joke.
What?
You want to hear a long joke?
No.
Joke. Okay, good. Okay, friction massage is one way we can actually massage the joint line right here. So basically we're taking our fingers, crossing them, slide them into the air, and we're basically just rubbing back and forth. And what I like to do is actually externally rotate the foot, so you'll see the foot down here. It's not pointed anymore, it's pointed outwards. And what happens is it gaps the space where the joint line is right here. So basically what you do is just kind of gently rub in there, and you find the area of pressure. And you do this for, I mean, gosh, sometimes it takes up to 5 minutes or so. Eventually you get marked decrease of tissue density is what we're looking for. So we're just trying to break up adhesions that happen just over the joint line right there. Now, once you do this, you might not be able to do it again for another 5 days or so. So a lot of times it takes a little bit of repair time. So I'll just kind of open up here just so you can see my fingers again, slide down, but basically I'm just kind of finding that joint line and just rubbing back and forth. Some people can't tolerate hardly any pressure at all. Some people can. And you'd be surprised, you do something like this and they might be able to squat deeper almost immediately. But you have to be very, very careful that you're not going to make it overly sensitive. So again, external rotation, open the joint line, slide down into it, get a double finger contact. That's mainly to help you out as the person doing it, not necessarily to help them. Okay, we're going to show types of stretchy taping. This is going to be for the medial meniscus. And scooch on a little bit that way. Good. All right, so I already pre-cut 3 pieces of tape. And this is rock tape, but you can use lots of different types of tape. So we won't spend too much time on this, but I'll show you a quick demo. So usually we do with the anchor one, we like to rip off about this much here, okay? And typically we find the area, which in this case we're looking at the medial meniscus. You slide down and we got to find an anchor point right there. So, oops, I shouldn't have done that. So here what we do is we attach it with no stretch there at the bottom. And what's going to happen is we're going to contour around the knee just like this, okay? And we're going to add about 10% stretch. Some of these tapes have stretch kind of built in, the elastic properties built in, so you don't have to bother too much with stretching them a ton. Okay? So I'm going to give about, say, 10% stretch there, and I'm going to go right over the area where it's bothering her and kind of contour it around. I know she was wearing lotion, so we'll see how far we get with this thing. There we go, right there. And I'm sure someone's going to criticize my taping. If you do, good for you. I'm sure there's better tapers out there, but this happens to work for me.
And for me.
And for me. So, yeah, if you want to learn proper taping, you should probably go to a course for it. So after this, we've already covered up the area right here. There is imagine like a star right there. I'm just going to cover the star up. Now we're just going to form an X. Okay? I usually rip it in the middle like that. Put quite a bit of stretch on it, lay it down, make sure there's not a ton of wrinkles in it. Good to go right there. Next one, again, we rip it in half. Bring it like this, go right over the area of pain, lay it down, put a little bit of stretch on it. See, she's kind of slippery. And there you go. So we got a taping job right there for a medial meniscus. This will also work for an MCL as well, and sometimes for the pes anserine. A lot of times with this, you can leave it on for about 5 days or so, but you have to make sure that they don't have a bunch of oil on their skin. Also, too, you can rub and mat it down a little bit more because it is heat activated. Sometimes the adhesives are. And also, too, you can put spray underneath it, but I think it's, I didn't need to do it for this purpose here as well, but I will put a link below to where you can find some of this tacky sprays. If you shower with it, it's completely fine, but you just have to make sure you dab it dry off and then just let it air dry. Now we're going to use some standard athletic tape. I don't love this stuff, but it does work in a pinch, and we're going to use some coverall so we don't tear her skin up. But basically what happens with this is it provides a little bit of movement check, we call it. So we're actually going to just form like an X on this side, and so we're going to restrict movement in, you went with me there, in this direction. Like if I was driving across there, we're decreasing the amount of gap in the joint space right there. So let's see, lift up a little bit, make sure you're in camera. And just for the purposes of the video, I don't have any elasticon or elastic tape here with me. So I'm going to use some of this white tape as the anchors. I don't love to use it as the anchor, mainly because these muscles in the area, when she moves her leg and contracts, it's going to bust them open, or it's going to impinge on some of her, I guess, her muscles' ability to move. So that's not really a good thing. So here's what we're going to do first. We're going to set our anchors. And again, with the taping thing, if there's an ACT out there, I want you to comment in on this and tell me I suck. Because ACTs are really good at doing this stuff. So I don't do them quite as often, but it works when it works. Okay, so we have our 2 anchors right here. Again, I wouldn't typically use this white tape here. I want something a little bit more elastic so her muscles can expand in there. So now what we have to do is we have to provide the check right here. So I'm looking for about this length. Okay, so I'm going to make 3 of these, and we're going to make a star formation, or an X rather. It's funny when you got to do this in a camera, and usually just go walk away and do it. Okay, so now we got the X right here. Okay, we'll stick this thing down. And for the most part, we want to see if it's irritated or unstable this direction, we want to make sure that we tape it pretty firm in the other, or in a position where it's comfortable. So in this case, she has her pain right into, where'd it go? Right into here. So I'm going to cover this area up. And actually, I probably should have done the X a little bit lower. But you can always do a secondary one as well. So this is basically blocking this motion going this way. Okay? And again, we can add some more. If I wanted to, I can go this way. And add another one this way if I wanted to. But, so here's what's going to happen from here. I know this looks super ugly, and it seems like it's not going to stay, but realistically, they usually do. So, you can provide another anchor. Here, and then fold these things over. Is basically what ends up happening. And then afterwards, you can cover these things up. See, I'm still on camera here. Good. About to use a whole row of tape on you.
Those muscular legs.
Of course, it's the muscular legs.
Yeah.
If anyone thinks that Laura has muscular legs, I want you to say so on the video, on the comments below. If not, I want you to tell her she's full of it. Okay, so this is taping to stabilize, and let's turn a little bit here. So we still have all this wrap here. Typically, you take like a whole cover and just wrap this thing up so it doesn't shred apart when she's actually moving. But this is going to basically take the place of doing a knee brace, but in reality, you could probably just buy a brace too. Wait, say it again. Say it again, so all the people listening, they're like, "Ah, oh, that's a terrible job." I want you to.
What? My fat looks like it's poking out.
No. So it feels stable is what we're looking for.
Yes.
Okay. So all we want is to see that it feels stable. And realistically, we should probably check we check capillary refill as well. So you have to check to make sure that all the vessels down to the toes are working well. We haven't obstructed anything. But yeah, you usually want to use a stretchy tape around that area. Okay, this is LEUKOTAPE. This is the tape that I would prefer for many different types of things. I'll put a link below so you can see. This is a cover roll, okay? Super important aspect of using LEUKOTAPE. The main reason is because LEUKOTAPE is sticky as hell. And that's good and bad, but I mean, you buy a cover roll and then you're in shape here. But basically what we're gonna do is we're gonna do a tab taping method. And so this one actually too is super sticky too. Make sure you clean the person off, alcohol swabs, and make sure that they are aware that see if they have any skin conditions as well. They might irritate it. So we're going to find the joint line here. Let's make sure we get the right spot here. Good. Okay.
If it hurts, it's right?
Yeah, right there. Yeah, if it hurts, it's right. Okay, so we're going to find the joint line right here. And since she's dealing with a medial meniscus issue, it's going to be, we're going to tape it just like that. What we're going to do with this tape is we're going to form a tab. Think of it like a skin tab, because it's pretty much kind of just like that. But you see how sticky it is already. I can't even like barely get it off my hands. So we're going to fold it in the middle, just like that. And then these other ends are ones that we're going to have right onto that cover roll. So we're going to find the area again where it hurts. We're going to make sure we don't hit the skin. I probably could have done a smaller tab, actually. Okay. Make sure we have a secure anchor right there on the cover roll. Now basically what we can do here is we can pull this way or this way, and we can actually go through movements like squatting and all that kind of stuff and see what movement makes her feel better. And basically what's happening here is we're kind of pulling like the fascial attachments to the skin. We're not actually moving the meniscus, but we're affecting the fascia and the overlying tissue, which actually attaches in there as well. So you find the position of comfort. Then we basically just lock it down. So let's just say, just for simplicity, let's say this makes her feel better. So now we're going to take it. Let's see if I can get the camera to see. So we're going to lay it on so it gets that tab right there. And then we're going to pull it all the way across. And just for the sake of video, I won't even bother attempting to improve that. But basically you can lay a couple layers down here and keep increasing the tightness of it. Just like that. Okay? And you see we did increase the tightness of it because you can see some of the wrinkles here on the coverall, which is typically what I look for. It's going to seem like it's really uncomfortable there, but I can tell you I've worn one of these things for like 5 days before, and you take it off and the skin and everything's like new. So again, this portion right here, this is a big no-no. Cut that thing off, make sure it's not on the skin. But this can stay on for about 5-6 days. It's a really, really rigid tape, and as long as you don't try to peel it up and pick at the ends, this can last for a little bit of time. Okay, after we've worked on improving the way the knee actually moves with meniscal injuries, and now it's time to stabilize it. So we're going to do a bird dog again. We've done this before, and we've done it with Laura, so let's see if she got it any better. I believe it was in the IT band video. But you're going to see some correlations with, you might see she makes the same faults if you want to go back and watch that one. But also, too, you'll see the correlation that knee conditions really need lateral stabilization and resistance to rotation. So a lot of the rehab is the same. Now, the first things that I'm noticing is she needs to push the shoulder, or push the hands through the ground. There you go. So we're, see the shoulder blade right here? Keep push, push, push. Push through me right there. Good. Next, let's bring the knees just below the hips. So bring them up to your, there you go. Good. Now, if there was a little tiny jockey riding on your back, I want you to push him up slightly. There we go there. Now, we're in a better starting position, although there's a couple things I'd improve, but let's not do it for now. Let's drive the leg backwards, drive the heel back towards the wall behind you. Make yourself real long. Good, you're so much better than last time. Now let's take the left hand and reach towards that window. Good, and squeeze the toothpaste. Squeeze, squeeze, squeeze. Good. So she's getting a little wobbly, and she has a little bit of sag where the jockey was sitting. So let's press that jockey up slightly again. And you notice that she's rotating the hips towards me. So let's correct that slightly. And I want you to push down into my hand slightly. Right there, good. Now we're looking at the shoulder here and see we got the sag again, good. Reach the arm really far to the window. Pause there and return. Good. Let's try the other side because there's a lot going on there. So let's start again. So the steps I like to take is, number one, let's find your middle. So arch up. We'll skip that part. Good. Let's push the jockey up slightly. Where's the jockey sitting on you? Let's get this jockey's right there. Push up a little bit. Push up. Good. Push up. Good. Push your chest through the ground though. You're arching here. No. Push up through here. More. I'll take that. I'll take that for now. Okay, let's drive the leg back. Good. I like it. So she's getting that knee locked out and she's driving the heel so she won't experience any spasm with the calf. And also too, look how nice this is right here where she's not rotating at all. She's not bringing that left cheek to the air. So let's drive that right arm out. Crush that toothpaste. I see that shoulder sagging again. Push that left hand in through the ground. Good. Now she's lost the leg. So drive hard through the wall. Through the wall. Good, good, good. And slow return. Let's do this one more time. I see the sagging again. Good. So there's definitely something we got to work on with her up there. She has a possibility of shoulder conditions if she continues that. So Let's drive a heel, I don't care which one. Good, I like it. The jockey though, push that jockey. Let's check the shoulder girdle. Good, much better. Crush that, crush, crush, crush. The reason why we have them crush is it helps activate the shoulder girdle on this side, but it really doesn't help this side over here. It's just to push the ground away to get that to work. To get this to work, we have to drive that heel through the wall, through the wall. Now give me one deep breath in and out, and keep driving, 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 and good, and relax. So that's the bird dog that I'd start some people off with medial meniscus injuries. There are other things to try as well, but this is one of the ones which hits a lot of things at one time. So with medial meniscus injuries, if you're going to palpate it, I would take the hand, the thumb right here, and slide all the way down the quad. You'll feel the quad drop off. You'll get into something hard, and now we are into the gully of the knee right there. You can also take it from the bottom range. We're going to go up the tibia, slide past the pes anserini right here, and now we're into the medial meniscus. And by the way, if you are having some pain in this area, it's important to differentiate between the pes anserini here and the medial meniscus, because a lot of times we can have an overspill of the gutter side. So this joint line right here is what we're looking at with medial meniscus, and it does encompass the entire range right here. Common things they'll complain about is clicking, popping, tenderness in this area as well. Sometimes their knee will actually lock into a certain position when it's more severe. But for the most part, a lot of meniscal injuries are not surgical injuries, they're rehab ones. And when it comes to doing a surgery on it, a lot of times we suggest earning your surgery. So sometimes they do need repair, especially when they lock. But if it's just uncomfortable and you still have full range of motion in your knee, minus this, then a lot of times it's a rehab case. With that in mind as well, a lot of people will complain about when they get their heel to their butt, such as when they're kneeling on the ground, this will hurt in the back side of the knee. It won't hurt on the front. Now I want to say that one more time. So on the front, if it feels like it's a stretching thing, then it could still be the quad, the tendon up here, or something around the kneecap. But if it's a pinching one and I'm doing the work for her, or she's kneeling onto the ground, there's really no work being done by these muscles in the back at all. So we're looking at the possibility of something getting crushed there, such as my finger just getting crushed between these back portions of the knee. Now, if you're unsure about a medial meniscus tear still, if it's something that you need to be concerned about, that's okay. There's other videos that we have in the series to address other questions on other conditions, so I want you to get them when they come out. And the only way you're going to get them when they come out is to subscribe to the channel below. So look for the little tiny logo that YouTube puts on this video and click on it. That'll subscribe you to the channel. You'll get all the information when it comes out. And next, thumbs up please. Give me a like on this video because you've already been watching it this long. You might as well. Next, I want you to scroll down and leave a comment. And this is extremely important. It's the most important part for me in this video because I want to hear what you want to know. I want to know your major questions on medial meniscus tears. Maybe you have a question about different types of grades. Maybe you'll ask if surgery is useful for it. Maybe you'll ask if there's other types of treatments, PRP, stem cell. You can ask anything you want to right here, right now. And if you're doing it on a phone, scroll down really, really far because it's below all those suggested videos. So please leave that for me. I will answer it on a podcast by myself or with an expert, or I'll comment just below right where you did on YouTube. Or lastly, I could make a video with your question on it right here on YouTube on meniscal injuries. Now we're on to the rehab section, or rehab theory. We've already gone over some quick tips and pain relief and some really basics of rehab, but I'm going to stop everyone right here and I want you to listen up really quickly because I've done this on the other videos and I want to make sure that if we're going forward into the video even further, that you're going into more of a theory of how to rehab. And if you only care about quick tips and how to make it better immediately, you shouldn't listen to the remainder of this video, honestly. This is reserved for people who really want to understand their condition, want to be able to program their own rehab, be able to talk to their doctor, their therapist, their strength coach about the reasons why they're programming what they're programming. And in the end of it all, you'll get a better understanding of how to program and prevent knee injuries from happening, period. Okay? So again, like I said, if you're not interested in that, you should turn away right now. Before I continue, I want you to first know that I know I'm going to talk about a lot of things right now, but I will go into a whiteboard demonstration and lay out some layers or some progressions of rehab that I like to do for meniscal injuries. Now, with meniscal injuries, the first thing you have to understand, and the first thing you have to understand about knees, is that it doesn't like certain movements. It doesn't like rotation, which would be like this, turning from here to here, excessively, and it doesn't like lateral bend. Now, can it do those motions? Yeah, I just showed you it could. The knee in general rotates about 5 degrees either direction, roughly. But beyond that, it doesn't like it. And especially it doesn't like it when you're putting repetitive loads upon it, say with running with poor mechanics. Now, consider knee braces for meniscus injuries and even ACL injuries. Okay, the knee brace, it's usually a bar with a dial. And the same thing goes on the other side. And the reason why this is because it's limiting that lateral bend, which is like, I can't even do it. So this would remain straight and this would go like a T, like tick, 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 tick. And rotation. And the reason why we're decreasing that is because an unstable knee, at least with an ACL injury, is not able to control that motion. So we need to protect it from subjecting itself to that movement. Now, when it comes to rehabbing the area, you could put a knee brace on it and just leave it at that. But realistically, there's more of a thought process now that if we subject our body and subject our knee to small doses of the poison that is rotation and lateral bend through movement, and especially exhausted movement, which we do at running all the time, then we're going to make it more resistant to knee injuries and more resistant to meniscal injuries, okay? If you've watched the video, or if you haven't watched the video on runner's knee already in the series, you should go back. And at the very tail end, I go over actually a whiteboard demonstration of how neuromuscular fatigue, or when form breaks down, it creates all these knee conditions, okay? They might present as a different type of thing. You might have a meniscal injury versus a runner's knee or chondromalacia patella, but really a lot of the mechanism is the same, okay? Just whatever breaks first. So as we go forward, just remember, we're resisting lateral bend and rotation, but also to let the body learn how to do that, we have to subject it to small doses in a controlled setting and then increase the speed and fatigue as we go. Let's go to the whiteboard. All right, now we're on to the good stuff. We're on to the progression of knee conditions, or the progression of meniscal rehab. So I wrote this all out for you so you wouldn't have to wait for my slow writing skills, but basically the progression of how we go is based upon the structure that's involved. Okay, in this case we're talking about the meniscus. So in contrast, you might say we have runner's knee. Runner's knee, the undersurface of the kneecap is involved, so it has a little bit of a different presentation, and people can't do certain things. An example would be a knee condition, a meniscal condition. They might not be able to bend the knee completely, approximating the heel to the butt. And with runner's knee, a lot of times they can't even put pressure on the cap, or they can't squat below 90. So a lot of these exercises in here might change slightly based upon what the person can and can't do. So first, I like to start with global stabilization. And in the past, a lot of times we started with local stabilization, which means that we give exercises specifically for in and around the knee. And I have put a couple videos out, such as quad sets and heel digs and stuff like that, which are a little bit more targeted to surrounding the knee or local stabilization, which does have its place. But the problem is if we don't have global stabilization, which means stabilization or really good function of the areas above and below the knee, then we're not going to have local stabilization either. So we kind of got to have both. And the idea came out, I think, about 5 years ago or so, where they were saying if you have a distal injury such as the knee, distal meaning further away from the body or the trunk, then we have to have proximal stabilization, which I do love the whole concept of it, but really we have to have both if we have an actual structure involved to a certain degree. So global stabilization might be things like, might be bridges, it might be planks, it might be part of the Trendelenburg test like we showed on here. It might be a lot of things. It might be lunges, squats, and so on. Local stabilization, like I talked about, it's right around the knee itself. So it's more of the conventional PT exercises that you'd see for knees, or corrective exercises for actually around the knee. Now, a two-legged challenge, all this really means is we are challenging the body in a closed-chained or foot-on-ground environment. And the reason why we do this is because that is how we function in everyday life. That's how you function when you run. You have foot in contact with the ground. So 2 legs, we start with that mainly because it's more safe. And we can put a little bit more weight upon the people. So squats, deadlifts, and small knee bends are examples of things that I would possibly put into here, as well as lunging. These are all good options in here. So once we've really mastered a 2-legged challenge, I like to go to a single leg challenge. And a lot of times we drop the weight significantly, such as imagine a double-legged squat versus a single-legged squat. This one is a lot more wobbly. There's a lot less possibility to put more weight upon it. So we got to definitely check form here before we go into a single leg one here. Now, when I talked about exposing yourself to the poison, this is where we're at in the rotational and lateral bend challenge. And it's not that we try to make the joint actually do that, but we try to resist the joint from doing that. And by joint, I guess I mean the entire limb. So in regards to stuff I would give here, I might give a rotational squat or an airplane. And if you've watched the other exercise or the other videos on knee conditions for runners, then you've probably seen an airplane already. So an airplane is a really wobbly one. You want to do it to the best of your ability where you still succeed, but it's still challenging, okay? It's I guess the lowest level of, not failure, but competency, okay? You need to make sure we're continually working on improving our body's ability to resist rotation and lateral bend. Now, you might wonder, when am I going to get back to running again? Well, we've done all this stuff, and then, so now we have slow and quicker based plyometrics. And if you consider what running is, it's basically a quicker based plyometric. So the reason why I like doing slow first is because we're working on mainly control, okay? Can you stack the joints? Can you resist rotation? Can you resist lateral bend? But now we're doing it in a jumping, bounding fashion. So an example of something I give here is a hop hold. And if you've seen people do repeated hops, then they're doing more of this. They're doing rebound, okay? They're working on the stretch response as well with the tendons and muscles, but also too, we need to make sure we have support before we can produce power, okay? So I like to have people, they land and they stick it and hold it. And I want to be able to, I tell them a lot of times, if you should be able to stay there, and I should be able to take a picture of you and have no motion blur if I had a long shutter speed, okay? You should be like a statue waiting there. And then we go again. Now we go into this, and hopefully you should have your control down, and you go down to more of a rebound. Now, this is a little bit different than, I guess, some people think of plyo. Some people think of plyo as just mainly jumping, but realistically, it's jumping in multiple directions, okay? So they would consider this more in the realm of agility drills. So I say half speed agility drills. And with agility, they usually think of cone drills on a field, at least in the running world, I've noticed. So agility drills are great because what we're working on is, again, the resistance of, say we do a side-to-side shuffle, stop, pause, and go back. And this is the resistance of, again, that caving to the side, that lateral bend, okay? And if we maybe go this way and then go into a 90-degree pattern, we're resisting some rotation, okay? So doing this half speed and really focusing on the ability to change direction is really, really important before we go to 75%. And then 100%, and basically in and around this realm, you're doing more running, and that's really where you want to be. So this is a rough flow of everything. Again, it does jump a little bit, like I said. If we have a little bit more structure involved, say the meniscus is completely frayed away and just torn to bits, then we probably got to start on local a little bit more readily than global. And if it's just a minor meniscal tear, I'd probably start in global more so than local. Or if there's not a tear at all and there's just knee pain, but there's not any really positive MRI findings or ultrasound findings, then we're going to start at global because there's not a real structural problem. And if you don't understand that concept I said right there, I do have a podcast coming out on types of tears or levels of tears, and I believe it's going to be around the high 40s, but you should look at it because it's the current classifications of at least soft tissue tears and tendon and muscle tears. More so than this is a cartilage tear, but it still kind of applies roughly the same. Now I know all that seems really confusing, but it doesn't have to be. A lot of times I like to show these to people to show there is a progress that we're going through. And as long as you just kind of take the exercises given in those certain sections, then we're going to be pretty good. And now we can blend this a little bit, and it's not necessarily black and white how we wrote it out as in levels. Because a lot of times it's dependent upon what the person or what you could do at each level, and you might be really bad at one level and then great at another, so we kind of blend them together. Now, again, if it seems really confusing, we do have an actual course that we're working on at Performance Place, and I'll put a link in the description below. It's not live at the time of me publishing this video. Okay, I'll let you know that first off. We're still developing it at the time, and we're trying to make it so it's really easy for everyone to understand, making it so you're not afraid of knee rehab, and so that you completely understand that there's just a process going on. Because a lot of times people get overwhelmed by how many things are thrown at them by a paper, by their PT or their therapist, and a lot of times they don't do it because there's just too much stuff. So we're trying to make it really easy in this course, and again, it's not intended to actually be a way for you to rehab yourself, but realistically it's the stuff that we go through here to rehab people. So it's very, very educational, or it's going to be when it's created. So check that out. The link is in the description below, and if you have not subscribed to the YouTube channel here, please thumbs up right now. Share with a friend who has a knee condition, and then subscribe to it. You'll get all the videos right when they come out. So I'll speak with you guys soon.